5, 4, 3, 2, 1. We are live, sir.
Good evening to all doctors. I would like to thank you all for taking out your precious time from your busy schedule. This webinar is organized by Banai, Behavioral and Neurosciences Academy of India. Banai is a not-for-profit organization formed in 2012. Banai has organized 200 plus programs nationally and internationally. Focus of Banai is to provide contemporary cutting edge on behavioral neuroscience. Banai is formed and runs under the guidance and chairmanship of Dr. E. Mohandas. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Deepak Raheja as the moderator for today's webinar. Thanks, Dr. Deepak Raheja, for accepting to be the moderator for the webinar. Dr. Deepak Raheja is a senior psychiatrist and psychotherapist, founder and director of Hope Care. Dr. Deepak Raheja uses an eclectic healing approach, combining with medical aspects with a rich experience in hypnotherapy, spiritual counseling, and alternate healing practice. Dr. Raheja has many research papers to his credit, including pioneering ICMR-funded research on neuropsychological deficits of chronic cannabis abuse. Dr. Deepak Raheja is a senior consultant psychiatrist to many diplomatic missions as a senior advisor to many media houses. I would now request Dr. Deepak Raheja to take over and start the meeting. Over to you, Dr. Deepak Raheja.
Thank you very much. Good evening, friends, colleagues, and respected seniors. It is a pleasure being here today, this evening, to be moderating this session where we're discussing a very, very important and pertinent clinical topic on alcoholism treatment, which a lot of time baffles us, confuses us, keeps us wondering if it is the pharmacological line of management that's going to work better, or should we lean more towards the psychosocial interventions? There are self-help groups. There are various treatment modalities, making it fall in a gray zone. We had to do a lot of juggling through to get these so-called Nasha Mukti Kendras within the ambit of the state mental health authorities to try and have a licensing moderating arrangement, so the violation in the name of human rights for treatment of alcoholism and substance abuse can be prevented. So it's a very important topic, and we have today none other than Dr. Mohandas, who's popularly known as Mohandas the Warrior, who's a walking encyclopedia of psychiatry. But I will let the honor of introducing Dr. Mohandas be left with the fantastic panel of chairperson that we have today. We're joined by Dr. UC Garg and Dr. Madhesia. I also feel privileged in introducing both of them. Dr. Garg, whom I know personally and very fondly to be a senior psychiatrist who's got a very, very roaring practice. He's a clinical man who has hands-on experience of psychiatry and treatment of substance abuse. He's currently the co-chair of the WPA section of preventive psychiatry. He's been the general secretary of the Indian Psychiatric Society National, and had a very fantastic and roaring tenure as the HGS office that he ran. He has also been the Secretary General of the Indian Association of Biological Psychiatry. And of course, we do know that he's been in the past the honorary treasurer of the SARC Federation of Mental Health, and has been the president of Indian Psychiatric Society Central Zone. It is an honor to have you here today, sir, and we'll be very happy and privileged to have you chair the session of the current.
Thank you very much.
Thank you, sir. May I also quickly, in a minute, also introduce Dr. Madhesia, and then I'll pass on the mic to the honorable chairperson for them to start the proceeding and introduce the chairperson and the topic a little bit more in depth. Dr. Madesia, of course, is again a hands-on clinical practitioner who currently runs a pretty unique indoor psychiatric hospital in Gorakhpur. He is full time into private practice, and he has more than almost touching 3 decades of rich clinical experience. He has been the General Secretary of IAPP Uttar Pradesh Uttarakhand branch. He's presently the president of the Uttarakhand branch of IAPP. He's the not just the member, but the co-chairperson of the community psychiatry section of the Indian Psychiatric Society. Thank you very much, sir, for agreeing to be here with us and to chair this session. I pass on the mic over to the chairperson to take the proceedings forward. Thank you, sir.
Thank you, Dr. Deepak, for introducing me in a very nice words. The topic of today's webinar is evidence-based pharmacological treatment of alcoholism. And the speaker is none other than Dr. E. Mohandas, a well-renowned international speaker, a great orator, researcher, and a very good friend of all of us. I will not take much time to express my views on the topic, but one thing I would like to share, we saw the lines of alcoholics standing in the queue up to 1 or 2 or 3 kilometers after the lockdown was lifted. And that showed how was the magnitude of the problem is. Alcoholism is broadly any drinking of alcohol that results in significant mental or physical health problem. Many terms, some insulting and others informal, have been used to refer to people affected by alcoholism. The expressions include tippler, drunkard, dipsomaniac, and sausage. In 1979, the World Health Organization discouraged the use of alcoholism due to its inexact meaning, preferring alcohol dependence syndrome. And the predominant diagnostic classifications are alcohol use disorder as per DSM-5 or alcohol dependence as per ICD-11. The World Health Organization has estimated that as of 2016, there were 380 million people with alcoholism worldwide, 5.1% of the population over 15 years of age. As of 2015 in United States, about 17 million, that is 7% of adult, and 0.7 million, that is 2.8% of those of age 12 to 70 years of age are affected by alcoholism. Alcohol use is quite common in India, both in rural and urban areas, with the prevalence rates as per various studies varying from 23 to 74% in males in general, and although it is not that common in females, but it has been found to be prevalent at the rate 24% to 48% in females in certain sections and communities. Geographically, it is least common in Africa. Surprisingly, it is 1.1% of the population and has the highest rates in Eastern Europe, that is 11%. A total of 3.3 million deaths, that is 5.9% of all deaths, are believed to be due to alcohol. Alcoholism reduces the person's life expectancy by approximately 10 years. And we all know that excessive alcohol use can damage all organ systems, but it particularly affects the brain, heart, liver, pancreas, and immune system. Alcoholism can result in mental illness, delirium, tremors, WK syndrome, irregular heartbeat, and impaired immune responses. Liver cirrhosis and increased cancer risk. Drinking during pregnancy can result in fetal alcohol spectrum disorders. So with these few words, I will expect from our learned speaker to enlighten us with his views on the problem of this alcoholism and the evidence-based pharmacological management of alcoholism. Thank you, Deepak. Thank you all. Now over to Dr. Madhesia to kindly introduce our learned speaker and invite him to give his presentation on the topic. Dr. Madhesia.
Good evening. Good evening, everyone. It's my pleasure to introduce Dr. E. Mohandas, sir. I think nobody wants introduction about him. Each and everyone is knowing who is Dr. E. Mohandas. He's very good speaker, rather good orator, and is good clinician also. If I will read, it will take another 7 to 8 minutes about his achievement. He is very good speaker, national as well as international level. He awarded so many national good awards and internationally also. So many, almost 100 sessions he has chaired, co-chaired this session internationally as well as nationally. He is the first, rather the last year, he awarded a WPA some award. This shows how so many people are linked to listen his speech present, the present topic. It is very interesting topic, the clinical evidence-based pharmacological treatment of alcoholism. I would like to say 3 things. The first thing is the manage the acute phase. If patient comes first, and you will see the first withdrawal symptoms. The second is the referred by others, partially treated, the response rate. The third major thing is the after withdrawal, or rather after abstinence, again he back to the previous society. The fourth thing is the family burden. If any person, any son or brother is drinking regularly, how they create problem in the family, that's the big problem. I think Dr. E. Mohandas sir speaks some about these matters. Thank you, Dr. Raheja sir. Hand it over to you.
Thank you, sir. I think without much ado, now I think we can't come in between Dr. Mohandas sir and the audience who is eagerly waiting to hear him. So Mohandas sir, over to you. So you'll have to unmute yourself, sir. Mohandas sir.
Yes.
Yes, sir.
Now it's okay.
Yes, yes, sir.
Can you see the slides?
Yes, sir. Very much visible.
Now it is clear.
Yes.
Thank you, persons, Dr. Uttamji and Madheshia and the coordinator, moderator Deepak Raheja, all my friends. And I will just discuss some of the evidence-based treatment of alcohol dependence syndrome. Can you hear me clearly?
Very well,
Yeah.
sir. Very well, very clear.
So, alcohol use disorder, it's a pattern of alcohol use that involves problems controlling your drinking, preoccupied with alcohol, continued use even when it causes problems, has to drink more to get the same effect, and withdrawal symptoms when you rapidly decrease or stop drinking. DSM-5, Dr. Garg has mentioned, the presence of at least two of these symptoms occurring within a 12-month period indicates alcohol use disorder. What are they? Taken in large amounts or over a long period of time, persistent desire or unsuccessful effort to cut down or control it, more time spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. You can have craving, a strong desire or urge to use alcohol, recurrent alcohol use with the failure to fulfill major role obligations at your work, school, or home, continued alcohol use despite having persistent or recurrent social or interpersonal problems, and you will curtail your important social, occupational, or recreational activities because of the use of alcohol. Also, recurrent alcohol use in situation where it is physically dangerous, and continuous use despite knowledge of having a persistent or recurrent physical or psychological problems. There are some terms. One is tolerance, that is a need for markedly increased amounts of alcohol to achieve intoxication or desired effect, or a markedly diminished effect with continued use of the same amount of alcohol. And withdrawal is manifested by the characteristic withdrawal syndrome for alcohol, or alcohol or closely related substance such as benzodiazepine is taken to relieve or avoid alcohol symptoms. In DSM-5, the severity of alcohol use disorder defined as mild, moderate, or severe. Mild is 2 to 3 symptoms, moderate 4 to 5 symptoms, severe is 6 symptoms. But DSM-5 eliminates legal problems as a criterion. But however, DSM-5 adds craving as a criterion for alcohol use disorder diagnosis. The American Society of Addiction Medicine, ASAM, 6 domains are there: acute intoxication and withdrawal, biomedical conditions and complications, emotional behavior and cognitive conditions and complications, readiness to change, relapse, continued use, continued problem potential, and recovery, and depending upon the living environment. These domains are really looked upon by the American Society of Addiction Medicine. There are 3 stages and 3 main brain areas implicated in alcohol. 3 stages are: one is the binge incentive, binge intoxication. Next is withdrawal and the negative effect. The third is the preoccupation or anticipation to use alcohol. The 3 areas which are involved are basal ganglia, extended amygdala, and prefrontal cortex. For example, the preoccupational anticipation, there is an executive function deficit. Withdrawal and negative effect, reward deficit or stress surfeit hypothesis. But initially, it is the incentive salience that is intoxication. In the intoxication stage, there's an increase in the incentive salience of alcohol-related stimuli and pathological habits. Withdrawal or negative affect state, negative emotional states. Preoccupation or anticipation stage, execution function deficits. I will not go to the neurobiology. Multiple neurotransmitters are involved: dopamine, opioid peptides, corticotropin releasing factor, and areas you can see the ventral tegmental area, central amygdala nucleus, stria terminalis, nucleus accumbens, etc. I will not go into details. Multiple systems are involved: cognitive control, motivation and drive, reward and anti-reward system. That is why sometimes Habnulab is also involved. I will not go into the neurobiology. Affect regulation, memory and learning, and stress anti-stress system. Now, when you assess clinically, before you manage it, you can use cut down annoyed guilty eye opener or cage questionnaire, easy to use it, or alcohol use disorder identification test or audit questionnaire. And in withdrawal, you have got clinical institute withdrawal of alcohol 10 item scores, abridged version. Cage questionnaire is cut down, annoyed, guilty, and eye opener. Questions are only 4 questions, scored 0 for no, or 1 for yes, 2 or more, that means that's an indicator. Have you ever felt you should cut down or your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? Have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover? That's called eye opener. Alcohol use disorder identification test audit. It's a crowded slide, and you can see 10 items here. And recommended cutoff score is 8. I will come to details. There is a self-report version is also there. The patient can fill it up. You can read all these things. But in audit, question 1 to 8 are scored on a 5-point scale from 0, that is nothing, or 1, 2, 3, 4. Question 9 and 10 are scored on a 3-point scale, 0, 2, and 4. The maximum score is 40. There is a consumption score. There is a dependence score. There is a alcohol-related problem scores. So how to interpret it? Audit 0 to 7, that is dependence score is below 4. That means the risk level is low. 8 to 15, dependence score below 4, risky or hazardous level, moderate risk of harm. And 4 or more, if it dependence score, if it is 4 or more, assess for dependency. If the audit total score is 16 to 19, but dependence score is below 4, high risk or harmful level, but 4 or more, dependence score, assess for dependence. 20 or more in the audit total scale, below 4 in the dependence score, high risk, but 4 or more, almost certainly dependent. You can use audit even in your practice, and if you have got some assistant, they can even do it, and there is a self-report by the client himself or herself. Alcohol withdrawal syndrome, the criteria is cessation or reduction in heavy or prolonged use of alcohol, at least 2 of the 8 possible symptoms after reduced use of alcohol: autonomic hyperactivity, hand tremor, insomnia, nausea or vomiting, transient hallucinations or illusions, psychomotor agitation, anxiety, generalized tonic and chronic seizures. And the criteria for delirium, everybody knows it: attention, awareness disturbances, and also memory, orientation, language, visual spatial ability, etc. no evidence of coma. Now, when you talk about alcohol withdrawal syndrome, what is the first one? What you get it? You can get even the withdrawal symptoms, minor alcohol withdrawal or the shakes. Initially, you can get it. Almost 80% of the people, we can get the shakes. You can get even sudden alcohol withdrawal seizures or rum fits. You can get even withdrawal hallucinosis or the horrors. Then you can have major withdrawal or delirium tremens within 3 to 4 days, even up to 7 days. Alcohol withdrawal seizures or rum fits, which I have already told you. This is delirium tremens is called complicated alcohol withdrawal syndrome. So put it in a simple way, if you take a timeline, onset 12 hours shakes 80% of the people. Peak is usually 1 to 3 days. Onset rum fits 12 hours, percentage is very low, not that low, 5 to 15%. Peak is 12 to 48 hours. Alcoholic hallucination, even alcoholic hallucinosis, you can get without clouding sensorium is alcoholic hallucinosis. Otherwise, you can get hallucinations once at 8 hours. Peak is 24 to 96 hours. When you say alcoholic hallucinosis, there will be a clear sensorium. Within 3 days, this is alcohol hallucination. Delirium tremens, onset 3 days, peak is 4 to 5 days. Though internationally they say 5%, we usually see plenty patients in this stage. There is a score called prediction of alcohol withdrawal severity scale called PAWSS. And don't worry about it. If you want to do it, it's a screening tool. I will not go into details of this. But this is important for everyday practice. Clinical Institute Withdrawal Assessment of Alcohol, called CIWA updated version. Maximum score is 67. There are two A's there. That is anxiety and agitation in that scale. Both are graded into 0 to 7. There are 4 H. One is headache, 0 to 7. Hallucination tactile, hallucination visual, hallucination auditory, 0 to 7. One N is there, that's nausea and vomiting. One O is there, that's orientation, only 0 to 3. And one S is there, that's sweating. And one T is the tremor. This is my way of putting it. Maximum score is 67. So in anxiety, I will go to 2 ways. Ask, do you feel nervous? And no anxiety at ease is 0, depending upon the severity up to 7, 0 to 7. Agitation, normal activity, that is also graded up to 7. Headache, fullness of in the head, does your head feel different? Does it feel like there is a band around your head? Rate the severity from 0 to 7. 0 means not present, very mild, moderate, moderately severe. Tactile disturbances, including tactile hallucination, graded from 0 to +7, including severe hallucination, moderate hallucination. Here you can get only some of the tactile disturbances, burning, numbness, +3. Visual disturbances, not present is 0, again graded up to 7. You can get moderate severity +3, but hallucination +4, severe hallucination, you can grade like this. Auditory disturbances, including hallucination, 0 to 7 grading. I am not taking much time to describe all this. And vomiting, also graded to 0 to 7, and depending upon nausea or even vomiting. Orientation, only you can 0 to 3 usually, that is +1, or completely disoriented. Some people put it 4. Paroxysmal sweats, no sweats, but that is also graded up to 7. Drenching sweats, more severe symptom. It is up to you to do that. Tremors, arm extended and fingers spread apart, no tremor, 0. Not visible but can be felt fingertip to fingertip, +1. And you can see severe with arms not even extended in DT. Now, scores of less than 8 indicate mild withdrawal. 8 to 15 indicate moderate withdrawal, marked autonomic arousal. And more than 15 indicate severe withdrawal and predictive of the development of seizures or delirium. But unfortunately, this withdrawal thing, vitals are not part of this score. Amount of benzodiazepine when we treat it does not include past risk, does not account enough for attention outside of serial addiction. Only 3 objective findings: agitation, sweating, and tremor. There's a short alcohol withdrawal syndrome scales, 10 items. That's the Likert scale. And less than 12 is mild withdrawal, and moderate to severe withdrawal more than 12. There's a short scale, SHOT, short scale, not short. That only you can get sweating, hallucination, orientation, and tremor. Score 2+ indicates need for benzodiazepine. Discontinue treatment of benzodiazepine when score is less than 2 on 2 consecutive occasions. This is an easy scale to use in our practice.
Well, just a quick interruption, sir.
Yes,
I
sir.
take one quick second to remind the audience to keep sending their questions, because for the best question that's going to be adjudged, there is going to be a very, very interesting reward of 5,000 rupees. So may I request the audience to keep sending their questions in the comment box so that they will reach us and we can tabulate that later. Thank you, sir. Please proceed.
Yeah, thank you.
Thank you.
During withdrawal, there are some neurotransmitters or neuromodulators are increased. One is CRF, norepinephrine, and glutamate. These are increased. CRF will produce stress and anxiety symptoms. Norepinephrine, autonomic symptoms and add to the anxiety. Glutamate, hyperexcitability and even seizures. Dopamine is decreased and serotonin is decreased, and really talk about the dysphoric symptoms. GABA is decreased, so anxiety symptoms, that's why we give GABAergic agents. Neuropeptide Y, anti-stress, opioids, dysphoria. Meaning, there is an upregulation of NMDA receptors as well as reduced GABA-A receptor inhibition largely explain the clinical symptoms. Increase in dopamine levels contributes to a clinical manifestation of autonomic hyperarousal and hallucination. What are the factors associated with DT development? History of previous DT, recent withdrawal seizures, specifically if left untreated, and CIWA average score that's more than 50, history of sustained drinking, systolic BP 150 mm, or patient with heart rate more than 100 beats per minute, last alcohol intake more than 2 days, age more than 30 years, recent misuse of other depressants such as benzodiazepine, concurrent medical illness such as pneumonia or active ischemia. Management outline, you have to put the patient in psychiatric intensive care unit if it is DT. Mild shakes and other things you can treat as an outpatient, but severe DT you have to admit. Medical evaluation including investigation. Periodic investigation means including liver function test, even coagulatory matter, all these things that you know. Periodic vital signs monitoring. Thiamine 500 milligram once or twice daily in 3 days. Depends upon some. I don't usually give it. I may not give it unless until there is a possibility of toxicose or even vernix. But most important is adequate hydration, adequate nutrition, including vitamins, appropriate sedation benzodiazepine, antibiotics to control infection if there are any, assessment to rule out subdural hematoma if there is a fault something. Always you see, examine the pupillary action, even the eye signs, adequate control of seizures. These are some of the guidelines. Pharmacological intervention is recommended when the score is more than 8 to avoid complication. It can be symptom-triggered treatment, diazepam 5 to 20 milligram, or chlordiazepoxide 50 to 100 milligram, or lorazepam 2 to 4 milligram. That is depending upon symptoms. Symptoms should be evaluated every hour in order to adjust administrative doses. Do we have enough staff to do all these things? That is another big problem. Loading dose regime, diazepam 10 to 20 milligram or diazepoxide 100 milligram every 1 to 2 hours. I don't usually advocate it in the center that I work. Fixed dose application. In case of high risks in developing severe alcohol withdrawal syndrome or previous seizure episodes or DTs, 24-hour monitoring of clinical condition is recommended. Diazepam 10 milligram into 4 times for first day, 5 milligram, or even you can change it into 4 days for 2 days. Then you titrate. Chlordiazepoxide 50 to 100 milligram into 4 times for first day, then reduced to 20 to 50 milligram into 4 days, 4 times per day for 2 days, then gradually reduce 25% per day from the 4th to 7th day. And it varies depending upon the severity of the condition. Now the drugs which are used, diazepam, you can give sometimes IV. Why diazepam should not be given intramuscularly is it has got a varied absorption. It is non-selective benzodiazepine receptor. But when you give diazepam IV, you have to give very slowly. We have to be very careful. Active metabolites, yes, because one of the active metabolites is a main one, N-methyldiazepam. Half-life is very long, and oral dosage, if you want to do 10 to 20 milligram, you can give IV or orally, totally in a day. Lorazepam, which I prefer, 5 to 20 milligram IV, I don't usually use that much. I usually use even 4 milligram to even 6 milligram. Active metabolites, no, it is not hepatically metabolized. Half-life is reasonably good. You can give 2 to 4 milligram IV or per orally, depending upon 4 hours or 8 hours. Midazolam, I don't usually use it because the half-life is very short. You may give in extremely severe cases as a, as a shotgun. Octazepam, which I like it, orally to give it because there is only oral preparation. It is available in India. In Kerala also we are getting 15 to 30 milligram per orally 8 hours because it is not metabolized through, for first pass metabolism is not there. Chlordiazepoxide Librium, many people use it. I don't usually give it. Half-life is very extensive and plenty of metabolites are there. 50 to 100 milligram per orally, that is recommended, but I don't use it. The newer agents are alpha-2 agonists, beta blockers, initial stages, some people say give. You have to be careful about the hypertension, etc. Some people give even neuroleptics, even olanzapine. Some people try that. It can be even given in alcohol withdrawal syndrome, even without psychotic symptoms. There are some papers. Carbamazepine and valproic acid, that was a fashion in NIMHANS a decade back, but I don't usually give. Gabapentin, some people give it up to 300 to 400 milligram. Topiramate, some people try, evidence is very low. Pregabalin, some people give it, evidence is low. Sodium oxybate, in some European countries, it is tried. Baclofen, some people give it in alcohol withdrawal syndrome, but you have to be a little bit careful. Cochrane review, evidence is out of the 56 studies, no sufficient evidence for in favor of any anti-epileptic agent for therapy for alcohol withdrawal syndrome. Even alcohol-related seizures, withdrawal seizures, no need of anti-epileptics unless and until there is a definite history of a trauma. There is a definite history of a previous seizure disorder, or there is a family history of seizure disorder, and you can think of it. And there is an evidence of the findings. Dexmedetomidine, a more potent alpha-2 agonist than clonidine, decreases sympathetic overdrive, release of norepinephrine. It can be used only as adjunctive therapy to reduce autonomic hyperactivity that cannot be controlled by benzodiazepine alone. But there are some suggestions yet to be studied. These are all case reports. Propofol, adjunct therapy for refractory case of alcohol withdrawal syndrome. Regularly, you should not give it. Promethazole, 200 milligram capsule are administered. I have used this thing when I was in Africa, but of no use. Gabapentin, recently it has come. 2018, there are reports. Baclofen and lorazepam are comparably in efficacy and tolerability in reducing symptoms of alcohol withdrawal syndrome. In Indian Journal of Psychiatry, there's an article, but not that much recommended as such. More research will be needed to determine where baclofen might have a role in second-line management of alcohol withdrawal syndrome on its own or in combination with benzodiazepine or other agent. This is the reason thing. So baclofen alone, evidence still needed. But along with the benzodiazepine, you have to be careful. Baclofen dosage has to be not high. Single dose phenobarbital, in addition to symptom-triggered lorazepam in alcohol withdrawal, it has come in American Journal of Emergency Medicine 2019, very rarely as a desperate remedy. Phenobarbital has been tried. Association between alcohol intervention and abstinence, meta-analysis, this is the network quantitative analysis, contingency management, plus psychotherapy possess the best rank of achieving the highest abstinence rate in treatment sessions. Pharmacotherapy plus psychotherapy possess the best rank in follow-up sessions. Pharmacotherapy was the only intervention that was statistically confirmed as effective in both sessions. Approved drugs for alcohol dependent syndrome or relapse prevention. FDA
Dr. Mohandas,
yes.
Dr. Mohan,
Yes.
there is one question. There is one question, very interesting question from Gagandeep Singh.
Yeah.
He's asking, is there a customized therapy for each patient or everyone is put through a standard treatment plan, especially in regards to the use of strong medication? How is the efficacy of drugs being evaluated that are being used to treat alcohol dependence?
See, these are well-known research with double-blind trials, and internationally that addiction specialists have used it, and that is how they get the approval from many countries. And umpteen data is there, and this literature is changed from there. Individualized treatment, people may not really buy it if you want to publish it. Otherwise, in practice, it is up to you. These are some of the guidelines. Now, FDA, FDA, US FDA, and European Medical Agency has approved acamprosate, disulfiram, and naltrexone. Naltrexone, Italy and Austria, GABA hydroxybutyrate, only in Italy and Austria. In addition to this, European Medical Agency, nalbuphine is approved. In France, baclofen is approved. Baclofen is not approved by FDA for alcohol dependent syndrome. If at all, some people have used in withdrawal syndrome, not in relapse prevention.
I think, sir, Dr. Mohandas, sir, I think Dr. Gagandeep is also perhaps hinting that when it comes to using strong medication, so I think essentially what he is implying is the regimes which use a fairly high dose of benzodiazepines, should they be standard or should they be customized? And I think
No, it
you
has
also
to
want
be. These are rough
customized.
guidelines depending upon the client that you have, depending upon the clinical condition, you can titrate it. I usually do that way. I don't usually use very high dosages. Disulfiram is FDA approved dosage is 250 to 500 milligram per day orally. I usually give 250 only. And even some cases, outpatient, even half of the tablet I use it. Meta-analysis of 22 studies, total number of clients 2414. This is the evidence 10 from there. Naltrexone, this is the classical Naranjo study and Volpicelli study. There initially they have told about 100 milligram. Now it has come to 50 milligram naltrexone per day rather than 100 milligram. But naltrexone people need a combined psychotherapy. Otherwise, if that benefit will not last much. Only 16 studies, but 2, 3, 4, 7 patients. Usually they say naltrexone and nalbuphine always supportive psychological treatment only benefit.
Sir, I would like a clarification here, sir.
Yes. Yes.
Do you see any distinct advantages of using nalmefene over naltrexone? And I'm primarily asking in the context of certain school of thoughts which endorse the use of nalmefene on as is required basis. So if there was going to be a binge drinking day, they recommend that a dose of 10 to 40 milligram of nalmefene orally might prevent the binge and would reduce the quantity of alcohol consumed. What are your thoughts on that, sir?
Yeah, you are partially correct, but nalmefene is not available in India, especially in South India. And only very few centers are using it. It is not FDA approved. Nalmefene. Okay, naltrexone, yes. Acamprosate, 1998 milligram. What if we give here 333-1112 rather than 1 BD? It has to be given at least around 1 gram. Not 1,000 ml per day orally. Meta-analysis of 16 studies. It has got a very good effect. Many people even recommend, even in liver disorders. I will come to that. Acamprosate. Long-acting injectable naltrexone, FDA is approved. To my knowledge, it's not available in our center in India, but in Delhi or Bombay, if it is available, wonderful. FDA approved. Yeah.
Any theoretical distinct advantages of using injectable naltrexone, sir? Any that you are aware about theoretical?
The importance is the patient will not miss it. 380 milligram intramuscularly monthly you can give it. That is only advantage. Now, FDA recommendation, American Psychiatric Association recommendation, there is no level A evidence. 1B evidence, naltrexone or acamprosate in moderate to severe alcohol use disorder. Disulfiram on level 2C evidence, but it has to be supervised and those people motivated to take disulfiram. It has to be under supervision. You have to be a supervised way of giving it rather than spurious giving, or the patient may not take it. Topiramate or gabapentin level 2C evidence is there. Evidence is very thin. Antidepressant drugs, only 1B evidence, only if there is a proper indication for use. If there is a severe depression, otherwise there is no indication for antidepressant. Benzodiazepine only in alcohol withdrawal syndrome, not to treat relapse prevention. But if there is a comorbid anxiety disorder, generalized anxiety disorder, you can give it. That is level 1C evidence. Avoid during pregnancy except drugs for specific disorders. For example, antidepressants are not contraindicated during any trimester of pregnancy. People say fluoxetine, will it produce problem? Bleeding if it is problem, whether septal defect, especially with paroxysm, that's all out now. Now, if it is deemed necessary, you can use antidepressant during any trimesters. But as a rule, please avoid drugs. Only level 1C evidence. Avoid acamprosate in severe renal disease. Reduce dosage in mild to moderate renal disease. Level 1C evidence. But still you can give it level 1C evidence. Naltrexone, avoid in acute hepatitis or hepatic failure. Otherwise, you can use it. Gastroenterology people say naltrexone, you can give it in liver disorders, which I can come to that. But if there's a acute hepatitis or hepatic failure, better don't use it. Evidence-based pharmacotherapy, disulfiram, better is 250 milligram, up to 500 milligram, but I like 250. Naltrexone perorally 50 milligram, not 100 milligram. Contraindicated naltrexone in the presence of comorbid opioid abuse, never give it. Naltrexone 380 milligram, 4 ml intergluteal injection, and side effects at the injection sites, etc. You have to see. Acamprosate 6 milligram 3 times daily, but you can give around, you can say that 113 you can still give. But diarrhea occurs in 17% of the patients. Gabapentin, recently there are some studies, that is evidence is there in UK, 600 milligram 3 times daily, but consider with comorbid neuropathy, starting dosage is 300 milligram 3 times daily. Topiramate, some people use it, but consider with comorbid seizure disorder, require 4-week titration. Side effects include paresthesia, and I rarely use this thing, but comorbid migraine, comorbid seizure disorder, I sometimes use it. Warniclin, some people use it, but only those people who have got comorbid tobacco addiction. Investigational drugs for alcohol use disorder, drugs targeting neuropeptidergic system, ghrelin receptor antagonist, oxytocin intranasally, neurokinin 1 receptor antagonist, glucagon-like peptide 1 receptor agonist, drugs targeting neuroinflammatory or neuroimmune mediators, PDE phosphodiesterase inhibitors, including rolipram, misoprene, tincamilast, etc. These are investigational drugs. Drugs targeting epigenetic modification, HDAC inhibitors, trichostatin, class 1 inhibitor. These are all sodium butyrate. These are all only experimental. Now, some of the psychopharmacology tips before I conclude. Disulfiram, first approved for the treatment of alcohol dependence in 48. It is an irreversible inhibitor of aldehyde dehydrogenase. Also inhibit other enzymes such as dopamine beta hydroxylase. Dosage is 200 or 250 milligram, 500 milligram. Recent meta-analysis has suggested it is effective, but supervised use is needed over non-supervised disulfiram. FDA guidelines is it is effective as supervised treatment. Acamprosate restores equilibrium of GABAergic and glutamatergic neurotransmitter system and also affects calcium metabolism. approved by FDA in 2004. It is effective for maintaining abstinence or reducing heavy drinking days. This is also okay. Complete abstinence you may not opt for that. 24 or 27 RCTs and the NNT is 12 to prevent return to any drinking. 2 tablets 3 times daily, but 112 is okay still. Opiate naltrexone, Deepak has already asked about it. Opioid receptor interact with the dopaminergic neurons via the GABAergic interneurons, thereby mediate dopamine release. It is an opioid antagonist work by blocking dopamine pathway, approved in 1995. 2014 meta-analysis of 19 RCTs revealed NNT is 12 and 50 milligram is the dosage. Extended release injectable formulation, which he asked, that is even 380 milligram intramuscular gluteal injection. But naltrexone, certain carriers, variant allele, especially which encodes mu-opioid receptor, had better treatment response to naltrexone. So some people respond better. They are the carriers of this variant allele. Nalmefene, antagonist of the mu and delta opioid receptors, partial agonist of the kappa opioid receptor, but 18 milligram daily, not approved by US FDA. Baclofen, selective gamma aminobutyric acid, B receptor GABA B, agonist anti-craving agent. Starting dosage 5 to 50, but better to put it maximum 10 to 30. Never go before that. I usually give even maximum 30, sometimes 40. Serious adverse effects over 100 milligram. Systematic reviews have been done from single patient case studies to case series with more than 100 patients. Sodium oxybate only in certain countries. Meta-analysis 50 milligram per kilogram per day in Austria. Meta-analysis didn't find sufficient evidence to assume efficacy of GABA, oxybate for lapse prevention in alcohol dependence. Topiramate, 7 studies found that topiramate yielded small to moderate effect size when compared with placebo. There is a genotype which may reduce the effects of topiramate on alcohol consumption. Gabapentin, recently, NNT is only 8. That is good. 600 milligram of gabapentin 3 times daily, decrease in the rates of heavy drinking, NNT 5, very good. Improved rates of abstinence, NNT 8, but very few articles have come now. Pregabalin may have also ruled, but limited data. Zonisamide and levetiracetam, evidence is nil. Carbamazepine and valproic acid may be used in alcohol withdrawal syndrome. Earlier they used to happen. Evidence is very, very low and modest. Hepatic dysfunction has to be considered when we give it. Ondansetron, some people give it at low dosage, 4 microgram, decrease alcohol drinking, increase substance, early onset patient with alcohol use disorder. There is a genetic variation in serotonin transporter gene, tryptophan hydroxylase 2, other serotonin receptors may modify treatment response. So some patients may get some benefit. We don't know. Warniclin, partial agonistic alpha 4 beta 2 and full agonist at alpha 7 nicotinic receptors located in ventrotegmental area, which regulate dopaminergic pathways, but may reduce alcohol intake, but more effective in less severely affected patients and who usually have got a comorbid smoking habit, 2 milligram per day. These are the new drug targets. Many new drug targets are there, including memantine. People have been trying, and ghrelin, oxytocin. This I have just mentioned, but evidence is very thin. N-acetylcysteine, there are many articles, but FDA hasn't approved. The last part of it, special population comorbidity in alcohol psychotic disorders, they do favorable response to antipsychotic medication. Which one is better? Anything, any antipsychotic. There is nothing called this is better. I prefer olanzapine provided there is no diabetes, because it will produce sedation. It is up to you to select any antipsychotic. Sufficient weight of clinical opinion to caution patients that even controlled drinking may lead to return of psychotic symptoms. That you have to warn. Biological markers of alcohol disorders, especially liver disorders, you have got many markers, but the sensitivity and specificity, gamma glutamyl transfer GGT has got sensitivity of 53%, specificity 76%, but MCV specificity is 94%. And whatever we do here is not that good, but GGT and MCV, it is better to do it. An increase of 40% or more in aspartate amino transferase and 20% of ALT, alanine transferase, has been reported to be suggestive of a relapse to drinking in alcohol-dependent men. Their sensitivity is 90%, especially for AST, and 80% is for ALT. So you can repeatedly do, even if they have relapsed, periodic checking is better. Alcohol dependent patient with liver disorders, diazepam, you can give it, dosage we know, avoid in severe, moderate to severe liver disorders because it is hepatically metabolized. Better to use lorazepam or oxazepam because it bypasses the metabolism. Better to avoid clonazepam or diazepam. If at all you use, you have to titrate the dosage. And indication in cirrhotic patient from hepatology people, they say baclofen can be used, but it can be probably safe, but not proven in alcohol liver disease patients. Acamprosate, yes, you can give it, and you have to titrate the dosage. Naltrexone, some people say, injectable, that is gastroenterology people, even topiramate, you can use it, varnicline, and then contraindicated is in cirrhosis disulfiram. In liver disease, new NEJM has put it, naltrexone you can give it, FDA approved, but caution to be used in acute hepatitis and decompensated people, which I told earlier. Disulfiram, never give it in decompensated patient. Acamprosate, you can safely give. Baclofen, the jury is questionable, undecided. Gabapentin, ondansetron, topiramate, and varenicline, we do not have enough data to suggest to use in liver disorders. Acamprosate can be used in patients with mild to moderate hepatic impairment. Severe, we have to be a little bit careful. Topiramate has not been formally tested in patients with liver disease, but a large trial indicates a safe hepatic profile. But we have to have again data. Baclofen has been shown to be effective and safe in patients with liver cirrhosis, but it is very controversial. Some people say no, some people say yes. So, liver disorders, disulfiram, hepatotoxicity, naltrexone also severe cases hepatotoxicity if it is very severe. Acamprosate, if the child book class C cirrhosis very severe, I think don't try to treat it, which I will come to it. Topiramate not reported. Baclofen in severe liver disorders, no. Ondansetron, no. This is the child puke score. 3 points means 1 point, 2.3, depending upon the severity. Here, better to avoid all these type of relapse prevention drugs. What about atomoxetine? Patients with ADHD, atomoxetine could reduce impulsivity trait, extinction of alcohol seeking is enhanced by a compound extinction and the noradrenaline reuptake inhibitor atomoxetine. It has a potential role in the treatment of early onset patients with, but as an adjuvant to the treatment, especially in ADHD. In the combination treatment, addition of acamprosate to naltrexone offered no incremental benefit beyond the naltrexone used alone. But individual choices may be there, no additional benefit. Combination of gabapentin and naltrexone may improve early outcome compared with the use of naltrexone alone, but in at least one RCT, this effect was not sustained. More data needed, but side effects matter if you combine. Pharmacotherapies for co-occurring substance use and bipolar disorder, we do not have a definite recommendation, but lithium is not metabolized through liver. You can combine lithium. Recommendation for treatment of this condition, comorbidity are preliminary. Accordingly, the conduct of larger randomized control trials for this comorbidities clearly needed. But lithium is not metabolized through liver. Especially depression, antidepressant medication can be given if there's a comorbid depression, not for as alcohol dependence, and gene polymorphism seem to have a pivotal role in response to medication for alcohol use disorder and depression, that you have to have a, Deepak has asked, you have to have a personalized treatment and you have to individualize treatment. You can go through this article, Expert Opinion on Pharmacotherapy 2019, beautiful article. You can go through it. Pharmacogenetic. Yes.
Dr. Mohandas,
Yes,
there
sir.
is one question. There is
Yes.
one question.
Yes.
Are drugs which are known to have a role in impulse control disorders, such as lithium fluoxetine, can be used in specific patients like binge drinking?
Absolutely, yes, if there is a comorbidity, but we do not have enough data on impulse control disorder or bipolar disorder, but if there's a specific indication, we give SSRIs. We can give it. Okay?
Okay.
As an add-on, yeah. But you have to know the interaction of the drugs. Genetic variation on maybe associated with better ondansetron and also naltrexone. There are some genetic variation, they say, but are we there yet? We do not, we haven't reached any specific recommendation. Whether a specific polymorphism in serotonin transporter gene, and we focus on pharmacogenetically driven treatment. So far, so we do not have an answer. I think I have to say thank you very much for this, the time that you have given to me. Any drinking, you can try pharmacotherapy, you can carry many medicines, but you have to individualize treatment and you have to see the comorbidity, which I've already told you. Thank you very much.
Thank you very much, sir.
Thank you. Thank you.
We
Dr.
have,
Mohandas.
it has been extremely informative deliberation and presentation on treatment of alcohol use disorder. We definitely stand enriched, and so does our audience, because we have a flurry of questions that have continuously kept pouring in. I don't know how many we'll be able to take and how much time we have, but I think with the permission of the chair, we'll try and take at least the important ones quickly to get your viewpoint on the incorporating certain comments and certain...
Dr. Raheja, can I ask one question to Dr. Mohandas?
Yes, sir.
Please.
Sir, how you will treat pregnancy with alcoholism?
Which one?
Pregnancy
with alcoholism.
Yeah,
Pregnancy.
that's a very good question. Usually there are reviews on
because I have two female.
Yeah.
Who are, one female is 4.5 months pregnant, and one lady is 7 months. both wife and husbands are drinkers.
Yeah, you're correct. There are good reviews on it. And acamprosate is supposed to be okay, but you know that the NNT number needed to treat is very high, 12 to 13. But you can still try, but supportive psychotherapy and other motivational enhanced treatment, etc. is there. You can only think of even reduction in the use of heavy drinking, because alcohol itself can produce teratogenic effects, and whether your drugs or even alcohol itself has produced it, we don't know. There are umpteen reviews on it.
Sir, I have
What
a very
about the benzodiazepine?
Benzodiazepine can be given, but it is not for relapse prevention. It is basically for even withdrawal states. Benzodiazepine is not contraindicated if there is a diazepam equivalent of more than 30 mm, less than 30 milligram, not much. There are some case reports, but we give not in relapse prevention, but only in alcohol withdrawal syndrome, or in those people who have got comorbid anxiety. You can give as a rescue medication, but a short term. But you have to see whether they have a subclinical depression. Then you put on antidepressants.
Sir, I have a very interesting comment and a question from Dr. Venkata Ramana, who is asking that what are your ideas about reducing doses of ethanol itself in controlled setting, which may improve patient compliance and may prevent the complication of alcohol withdrawal in terms of seizure or a possible delirium tremens. What are your thoughts on that, sir?
Your thoughts are very good. We are only we are advocates. Whatever we tell the patients, they are the masters. They will adjust their treatment. They may stop it or they may reduce it. But our basic aim in alcohol dependence is reduce quantity of drinking and reduce days of drinking, which will not affect their social, their work-related or family issues. That is the aim. So
another question. Thank you. That's useful. Another question from Dr. Anima, wherein it is being asked that alcohol is known to produce structural changes in the prefrontal cortex, which means that it is likely to distort the cognitive functions, the planning, organization, problem solving, and some executive functions. And because the preoccupation and the anticipation phase is mediated through the prefrontal cortex, in your opinion, are these patients going to pose a more difficult challenge to pharmacotherapeutic interventions of treatment in alcoholism?
Alcohol-related cognitive issues, majority of them are reversible. They are reversible. Majority of them are reversible. So still you can motivate them and you can treat them, and the prefrontal functioning will come back to rather normally. Yes, it is possible.
Dr. Tajveer Walia is asking an interesting question, even though you touched upon the question on a slide, but this is also still my confusion, and I'd like to also voice it through him. He's asking a very simple question. Is a combination of anti-craving agents more effective than a single drug? Even though you did touch upon in a slide, we'll just maybe want a little bit more of clinical pearls in terms of should a combination of anti-craving agents be used? And if yes, what is the best combination that could work?
Acamprosate and naltrexone, people have tried, and initial reports that they had a better response. But the current evidence says that they do not have any added benefits, current evidence. But I also used to use it, acamprosate, naltrexone initially. The previous reports were there. There were reports in CNS drugs. It may be beneficial, but no added benefit with the current evidence. Thank you.
So also, just another thought, I'd like to know your views on the other evidence-based use, not really the FDA or the Drug Controller of India approved drugs, but the evidence-based pharmacotherapy like gabapentin, varenicline. I mean, what is the possible role of adding them with the primary agents, anti-craving agents?
If there is alcohol dependence, if a comorbid tobacco use, Warnickel can be an add-on treatment. Not only standalone, add-on treatment, no problem. Right, that is one. If the person has got ADHD, better is add-on atomoxetine. That is already tried, especially in young people, early onset to this thing, atomoxetine a lot, especially the Italian study and the Benegal from Nimans have called atomoxetine is very effective. But the recommendation is there, atomoxetine can be given, especially those people with ADHD. But Bangalore Remand study is different, Italian study is different. Atomoxetine alone can be tried. Some people, I give atomoxetine a lot in young people. Impulse control disorder, somebody asked, I usually add SSRI. My preferred one is fluoxetine because it has got more half-life. Yes.
Dr. Gurvinder Pal Singh from GMCH Chandigarh wants to know that what would be the highest dose of baclofen that one could use in somebody who has hepatic dysfunction? What is
hepatic dysfunction, more than 30, you should not go. Though the recommended doses up to 100 milligram, more than 30, you should not go.
Dr. Anima has asked about the use of anti-craving impulse control agents like lithium and fluoxetine, which you've already answered, sir. There is also another interesting question by Dr. Aninda Sedana, wherein she wants to know that if a patient with comorbid opioid dependence and alcohol dependence lands up in the emergency with delirium tremens, what should ideally be the course of treatment?
Yeah, delirium tremens, you treat it, which I have already outlined, because that is the detoxification process. But on the relapse prevention, never use naltrexone in those people who have got comorbid opiate problems. Otherwise, you can choose it.
So, sir, we also are seeing that there is an increased incidence of alcohol dependence syndrome being presented in women population, especially in urban cities, you know, and to some extent that might be related to comorbid anxiety disorders that they may be. So what is the role of the corticon stimulating factors, the antagonists that could be used, and do you have some experience of that, sir?
Basically, in the genesis of this thing, that is a Marengo study. That is, there's a subclinical panic disorder or social anxiety disorder in bipolar 2 patient presenting with this thing. In order to control the phobic states or panic states, they drink alcohol. And in Marengo study, have told that CRF agents, especially hypothalamic agents, CRF antagonists, people have tried, but we do have a very limited evidence in the management. That is, you are referring to the Narango studies. Okay, that is the evolution of when you talk about how this after the reinforce. There is a how you develop alcoholism. I do have my own way of looking at it. This is one part of it. That is one part of it, and there you can think of CRF antagonist and etc. But evidence is thin.
Dr. Arun Marwale also wanted to know if the delirium tremens presentation has stood the test of time in terms of how it was narrated at the genesis, and how do the symptoms present now? Has it been a stable symptomology, or the presentation has changed over a period of time, sir?
No, it is almost the same, provided if you look for it, it is the same. If you look for it, it is the same. Only problem is when you have to treat a DT, what I used to say, after 72 hours, always in the psychiatric ICU, patient may be all right, but on the third day, they will start having problems. So don't disturb them proper, but early. You have to wait for that. On the third day or fourth day, they will start like this with the severe delirium tremens. And the picture is not different, and we can manage very well, but very rarely sedation, as there are some reports. I have used even phenobarbital in severe refractory DT without sedation. I have tried it, even phenobarbital personally, but only there are some case reports in intractable cases. Otherwise, mainstay is benzodiazepine. But if there's a comorbid psychotic symptoms, sometimes we have to give antipsychotics. Even my preference is olanzapine. Gradually, then you reduce it. Whether, but usually it is not recommended. Only when there are psychotic symptoms. Okay, right.
Dr. Garg, you had an observation, sir.
Yeah. Sir, Dr. Mohan, although
Yes.
my question is not related to today's topic,
Yes.
but I am a co-chair of WPS section for preventive psychiatry.
Yes.
So I need your wisdom on the question whether the prohibition of the alcohol in the states is helpful in reducing the incidence or prevalence of alcoholism.
Prohibition, I think historically also, prohibition, historically it hasn't really done anything good. Mughal studies, if you know the Indian history itself, you know it. So similarly, if you force anything, there is a chance to even try it. If you see in a place where don't spit it, you will see maximum spits. So you have to psychoeducate them for what are the harmful effects and what are the deleterious effects, how it does affect not only your cognitive faculties, your routine functioning, your family functioning, your financial matter, their social image, etc., then gradually try to motivate them to withdraw rather than restrain them, almost like forced, what do you call here, quarantine, rather than the usual quarantine. Forced lockdown. Okay,
Thank you.
A very, very basic question, sir. In terms of the binge drinking pattern versus a continuous drinking pattern, what are the differences in treatment challenges and the outcome in terms of your observation and experience?
You are talking about a binge pattern.
Yeah.
Whenever you get a binge pattern, drinkers always rule out cyclothymia and even bipolar disorders. You have to always rule out. Similarly, as you have rightly told about the phobic and anxiety symptom, especially in bipolar 2 patients, there you have to see. Otherwise, there is no role for mood stabilizers like lithium. Only those people it may be effective. Okay, right. And the other triggers are the usual thing, that's that so-called type 2 alcoholism. But when I say the type 1 and type 2, there are differences, especially the Austrian category. There's less typology, type 1, type 2, type 3, type 4. Type 1 is a social drinker, type 2 is the classical alcohol dependent, type 3 is your comorbid anxiety, panic, etc. Type 4 is if there is a Schizo disorder history, if there is intellectual disability, head injury, etc. That is a less typology. Okay. So depending upon the category, you can do it.
Can we having stress?
Stress always has got a role. That is why that CRF, especially stress induces, it can initiate drinking habit. But the problem is to de-stress it, you have to educate that this fluid is not the solution for that. There are better ways to control the stress. Okay.
So if we see alcohol, the substance, as a obsessional preoccupation, A, the role of anti-obsessive drugs, B, I have also seen in my clinical experience that the patients who recover using self-help groups like Alcoholic Anonymous almost start following it like a cult. So there is almost that extreme obsessional preoccupation with the 12-step program where they are living the program night and day and just talking about that, that to some extent, the dysfunction in life continues to be evident. What are your thoughts on that, sir?
Answer is very simple. Alcohol drinking habits, even have a dependence, is also going through an obsessional thinking. Am I to drink or not to drink it? Okay, that is one part of it. But as a therapy, not only alcohol therapy, spiritually augmented cognitive therapy has done additive role And that I will not call it obsessional thinking, because it is a spiritually augmented or religiously augmented and all a group oriented or cult oriented thinking which can benefit them. It has their supportive role. It has been documented. Spiritually augmented therapy as an added role. Absolutely.
So is there Dr. Anima wants to know if there is evidence, experience for alternative Ayurvedic and other therapies and treatment plans in the treatment of alcohol dependence syndrome.
To my knowledge, no, my relatives are in Ayurveda, particularly and Coimbatore Ayurvedic pharmacy, but there are no specific guideline, no specific treatment as such there. Though they say even you can control with certain ingredients, and also if there's a comorbid diabetes, you can take madhumeha, etc., some leaves, but evidence is very thin. And same is true for acupuncture, even Chinese. I do have some articles, but evidence internationally accepted is very, very thin. And Ayurvedic preparation, sometimes whether it is hepatotoxic or anything, we do not know. So in a hepatically dysfunctional patient, never venture these type of things unless and until you know better. Thank you.
Right, sir. So there are many, many more questions, but I think we are almost running short of time now. I think I will pass on now to Dr. Medesha and Dr. Garg for their final comments so that we can come to the closing.
Thank you.
Thank you, sir. You are nice, excellent, most educative lectures you have given. Thank you. Dr. Garg, sir.
Thank you very much, Professor Mohandas, for giving an excellent lecture on alcoholism, pharmacological management, evidence-based. You know, in our practice, many times we are not able to follow the guidelines prescribed for the treatment of a patient who comes with different comorbidities in a different not only comorbidities, but in a different phase of the alcoholic withdrawals. So we have to customize, as you said, treatment according to the patient's need. But sometimes what happened, there are involvement of licensed psychiatry, where gastroenterologist and neurologist has to be involved. In these type of cases, it becomes a difficult for a psychiatrist to keep his opinion according to the guidelines. What do you say about this situation?
Yeah, you are absolutely correct. Evidence-based is okay, but we do evidence-informed practice. Okay?
Yes.
And there was a question, what will you do in alcohol, hepatic encephalopathy? Manage that first, rather than thinking of it, the medical complications. Then only you think of, already it has reached that stage. So forget about your relapse prevention now. First of all, you treat the medical problem. And I need not talk about how to manage it. I can even easily say, yeah, I know the regime, but I will not take much time. And first of all, treat the acute medical condition, then only manage. Garg, you are correct. We are doing it evidence-informed practice. Okay.
Thank you.
One last question. Dr. Amol Gulhane also wants to know if you have experience or thoughts about the disulfiram and naltrexone implant, not the injection, the Vivitrol, but the implant.
No, somebody has suggested, especially from South Asian countries, disulfiram implant. People have tried it, but here we haven't heard about it. I'm in India. I haven't tried it. I don't have an access. There was a suggestion some 8 years back, disulfiram implant, But after that, I have been seen 8 or 10 years back. I have read that, but I don't have any literature after that. Thank you.
Thank you again, Dr. Mohandas. And before we close the webinar, I request Dr. Deepak Raheja to kindly announce the best question asked in the session. Do you have a list of that, sir?
I will leave that prerogative to the chair. I think let Dr. Mohandas have an opinion and maybe
No. I will not comment on anything. You can do it.
There is also
yourself and Garg can do it, not me.
Dr. Garg Saab, Dr. Madheshia, please opine, because we wanted to encourage questions and there's been a flurry of questions. Unfortunately, I haven't been able to take all of them. I tried to pull in a lot of questions, so I would need definitely the assistance, the chair to be able to.
Sir, आप final opinion दीजिए.
There are so many questions, but the best question selected by the jury is question raised by Dr. Gagandeep. Can I ask Amita to kindly put that question again? Hello, Amita.
So just a second,
when you do,
she's uploading the slide, sir.
Okay. Okay.
Please do the slide.
Yeah. So is there a customized therapy for each patient, or everyone is put through a standard treatment plan, especially in regards to the use of strong medicines? How is the efficacy of drugs being evaluated that are being used to treat alcohol dependence? This question was asked by Dr. Gagandeep Singh and has been judged as the best question for this webinar. Congratulations, Dr. Gagandeep Singh, and you will be getting a e-voucher of rupees 5,000 from the Banai.
Congratulations, Dr. Gagandeep Singh. You won yourself a 5,000 rupees e-voucher for Amazon shopping. Once again, thank you very much, Dr. Mohandas, for an extremely informative lecture. We were all spellbound listening to the clinical pearls that we were going to take back and be able to utilize in our practice. I thank you very much. I thank the Banai team for organizing this webinar and for giving us the opportunity to be here. Thank you very much, sir. Have a great evening. Enjoy your dinner, and we look forward to seeing you again on a very stimulating topic again on Banai Talks very soon in the near future. Thank you very much, sir. Have a good night.
Thank you,
Dr. Raheja. Thank you, Dr. Mohandas.
Thank you,
Banai.
Thank you, everyone.
Dr. Garg sir. Good night.
Bye-bye.
Okay.
Good night.
Thank you.
We hope to see you again on coming Tuesday at the same time. Please block your dates every Tuesday, 8 p.m. to 9:30 p.m. Interested topics will be covered. For the upcoming webinar is evidence-based treatment of cannabis dependence by Dr. Atul Ambekar on 5th of January 2021. I will request all of you to block these dates and register yourself for the webinar. Do send us your feedbacks and comments on the email given info@medisquare.com so that we keep on improving our webinar series. Till then, stay safe and enjoy. See you soon next week.
Thank you. Thank you, Venu. Thank you.
Thank you.
Bye-bye. Good night.
Good night.
Thank you.